Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie Dialyse et Transplantation, Marcus at Home welcomes Dr. Katrin Kemp Gudmundsdottir in Reykjavík, Iceland, in order to discuss systemic biomarker and ECG-based screening to detect atrial fibrillation in the general population based upon her STROKESTOP II study. Dear Katrin, thanks so much for joining us as our first expert from Iceland.
Thank you so much for having me. This will be fun.
Thank you from my side as well. I'm very happy to have an excellent round here with our invited guests. Katrin, I'm not sure how to pronounce the second name. I stay with Katrin, and she actually studied medicine at Heidelberg University, speaks very well German, but we'll do this in English. Then went over further to Stockholm, obtained a PhD at the Karolinska Institute in 2020, and has a strong research interest in atrial fibrillation and the epidemiological aspects of AFib screening. That's what we'll be talking today. We're also very honored to be joined by Dominik Linz, who's an old colleague, so a long-time colleague that we know from Hamburg University, where we worked together as residents even, and Dominik went on further to obtain a PhD in Maastricht with Uli Schotten, and I think then went on around the world to Australia, in Adelaide, where we really started his electrophysiological clinical career, I think, and came back to Maastricht, where he's in the meantime head of electrophysiology and professor of comprehensive atrial fibrillation management. And I think since 2022, Dominik, you're also professor at the Faculty of Health and Medical Sciences in Copenhagen. Is that right?
Yes, that's correct. Yeah,
we do have a true expert here in AFib to help us with the understanding of Katrin's study. And well, without further delay, I'll be happy to invite you for your presentation, please.
So my name is Katrin Kemp Gudmundsdottir. I'm a medical doctor and a cardiologist working in Iceland, but I did my research in Stockholm, where I studied cardiology and did my PhD, and my project was the STROKESTOP II study, and I want to present it to you here. These are my conflicts of interests, and well, the ESC guidelines suggest population-based screening to be considered to detect atrial fibrillation in individuals over 75 years or those at high risk of stroke. So the aim with the STROKESTOP II study was to see if screening for AF, and I will use AF from now on instead of atrial fibrillation, if screening for AF enhanced by NT-proBNP for risk stratification would reduce stroke or systemic embolism in the intervention group compared to the control group. We also wanted to study the prognostic value of NT-proBNP in AF screening. So to the methods, the intervention group was all 75 and 76 years old, 6-year-olds in Stockholm, or 28,712. They were randomized 1-to-1 to serve as an intervention group invited to screening, or to serve as a control group where they received no information and were not invited to screening. And no intervention. We then had a 5-year follow-up with register-based outcomes, and the primary outcome was stroke or systemic embolism in the intention to screen group, or the whole group invited to screening. At the screening visit, those that came had blood analyzed and NT-proBNP measured, and those with NT-proBNP under 125 nanogram per liter were defined as a low-risk group, and those with NT-proBNP over 125 nanogram per liter were defined as a high-risk group, and this was based on previous studies, this cutoff limit. The low-risk group did one-time ECG at the screening visit with a thumb ECG, and the high-risk group went on to do 2 weeks of intermittent screening, doing 30 seconds 4 times daily of this thumb ECG. In case we found atrial fibrillation, we referred them to a cardiologist for discussion and oral anticoagulation treatment if indicated. Now to the results. After excluding those that died, the group invited to screening was 13,905 individuals, and the group not invited to screening were 13,884 individuals. These groups were comparable in all aspects. Now, to the participants that accepted the invitation, we had 6,843 individuals accept the invitation, which is a 49.2% participation. After excluding those with previous atrial fibrillation diagnosis, the high-risk group accounted for 60% of the participants. And probably no need to say, but these groups were not comparable according to medical and medication history. The high-risk group was sicker, had more hypertension, chronic kidney disease, heart failure, etc., and more medications. Now, we found new atrial fibrillation in 165 individuals, or 2.4%. And of those with previous atrial fibrillation that were not on oral anticoagulation, there were 54 individuals. So untreated AF, or atrial fibrillation not on anticoagulative treatment, was 3.2%. If we compare the low-risk group to the high-risk group, the high-risk group had more than double the risk of developing atrial fibrillation over the follow-up time, as you can see here in this picture. The prevalence of AF between the intervention group and the control group was similar during the whole period. There was no difference there. And there wasn't a difference either in oral anticoagulation use in AF patients between the intervention group and the control group. It went from 68% to 82% in the 6 years, so it increased over the years, but in both groups. Now, to the main result, so stroke or systemic embolism in the intention to screen group. As you can see, there was no difference with a hazard ratio of 0.96 and a p value of 0.412. So the groups were the same. And this to say, just to be clear, that this is the intention to screen group. This is the intervention group is both the participants and the non-participants. That is sometimes a little bit difficult to understand. It's not only the ones that participated. We also examined the low-risk group compared to the control group with regards to stroke or systemic embolism as a safety measure, because we did not screen the low-risk group as intensely as the high-risk group. And there the low-risk group was had significantly lower risk than the control group. And interestingly, if we look at the subgroups, if we sort this into subgroups, we can see that the yellow group, which are the non-participants in the intervention group, compared to the control group, have higher incidence of stroke or systemic embolism. If you compare the high-risk group to the control group, there is no difference. And if you compare the low-risk group, like we did before, to the high-risk group, there is quite a large difference. But these are observational data, of course. These are a bit biased. But yeah. So we concluded that AF detection or anticoagulant treatment was similar in the intervention group and the control group. Only 49% of those invited participated in screening. There was no reduction in stroke or systemic embolism in the group randomized to be invited to screening compared to the control group. But anti-proBNP can safely be used to determine whom not to screen for AF. And we presented this in circulation simultaneously to the presentation at the ESC.
Okay, well, Katrin, thank you so much for this excellent presentation. It made a few things clear to me because you really pointed out where the important issues are. So somebody who is invited and didn't participate then is in the intention to screen included, and it's not like an as treated or as screened population where there might be another difference. I would like to invite now Dominik to ask some questions and comment or whatever comes to your mind, really, Dominik. Obviously, we might have another 1 or 2 questions as well if there's some time. So, Dominik, please.
Yes, yeah, thank you very much. And Katrin, yeah, congratulations to you and the complete group putting this study together. I think it's a big effort, of course, those screening studies ending up in a manuscript, in a circulation, which is, of course, great, but I think it cannot really reflect how much work is behind such a big effort of actually screening so many individuals. I think there was, of course, also the STROKESTOP I study, right? So this was actually a recent study where mainly patients with the age of 75 and 76 plus a risk factor were included. And this study was positive, right? So this and this recent study was also then really contributing to the recommendations in the ESC guidelines. Now you suddenly have the STROKESTOP II study, and this is negative. But at least not positive, neutral. Yeah. And so can you maybe tell us there a little bit about this? So what do you think is mainly the reason that actually this was negative?
Yes, I think, I mean, we see, of course, one of the big factors is, of course, participation. We know that those not participating, and we have looked at them and presented those studies. They are sicker. They have more risk factors. They probably benefit more from attending the screening than those that come. They are a bit. I mean, this is of course selection. So we have the ones that are more healthy and of lower risk. But still only 49% attend. So we need to get people to, I mean, screening only works if people attend. That is just the basic idea with screening. And what I think actually is quite interesting and good about the STROKESTOP studies is that we start the randomization with the invitation and not the ones that accept, because that is already a selection, of course, in studies where you already have included, and then you randomize them to screening or not. So this is quite pragmatic. Both of those studies are quite pragmatic. It's not completely the same endpoint. They had a combined endpoint in the first study. And we also saw that the lines, they really diverged only at the end, like at 6 years or something. So the follow-up, and our curves do the same, but they haven't, not significantly so. So, of course, we will have a 10-year follow-up or even more, you know, we will follow this up and we will combine them maybe and look at them. So this is, but I mean, society screening is it's expensive. It needs to be shown to have effect for, you know, for whole of society. We know, of course, kind of that if we screen, we will find something, we can treat it, but we also want to be careful of downstream negative effects. And we need to, but we did not see bleeding or complications in the group compared to the control group. So this was quite safe.
Yeah, I think that's also a very important point, right? So at least you don't harm.
Exactly.
And because there have been also other screening studies, obviously, where just screening for something and then initiating a treatment also harmed in certain aspects. But this was at least not shown here. You mentioned now the participation, which I think is also a very, very big challenge in this regard. The participation was the same in STROKESTOP I and STROKESTOP II, right? Approximately. Yes. It was in STROKESTOP I, I think it was 51 or 50% or something, and now it's 49%.
There's also, if I may, I think the what you're getting it probably, I'm sorry for interrupting, but I think that there's a difference in STROKESTOP I and II also in detection of AF, because they found more AF a little bit because they screened more. Of course, that is what happens if you screen, you will find it. But they also had quite a few more with previous AF, but were not treated and were put on treatment. So the difference was almost 2% in AF, you know, treatable AF. So that is also a difference between the studies, which might help with the difference of the treatment, of course.
Yeah. the participation was twice the same in STROKESTOP 1 and STROKESTOP 2. So didn't you consider changing something in the onboarding process or actually trying to do something to improve the participation? Because you knew already from STROKESTOP 1 that the participation is actually not optimal, right?
Thank you. Yes, we actually did. We had different screening centers. We only had one in STROKESTOP 1. We had 3 in Stockholm in STROKESTOP 2. We put them there where the worst participation was in STROKESTOP 1. So we centered them around those areas. We put out, we opened up a site in all the 8 languages, the most common in the Stockholm area, to try to get people to understand and see.
Yeah.
And we did get better participation where we put the centers. That is obvious that the closer you get, or it improves participation. But we actually wanted to have more, but it was a little bit. Opening sites is also difficult.
Yes. Just to put this into perspective, sorry to interrupt. I mean, we're talking roughly 50% participation in a screening study. We invite the whole population of a certain area at a certain age. I think this is incredible, as Dominik said, and this is just Scandinavia or Sweden. It probably works in Iceland, Denmark as well. This will never work in Germany. I mean, we wouldn't be talking 50, but we're talking 15%, if at all. So I think you really have to be congratulated to reach that.
Yeah, we did our very best. We tried, but we did not. And yes, we didn't achieve any more. And like I said, people were. I don't know what, but I mean, the technology is developing. So we are, of course, there's still quite a strong belief that this will do good for society. So, I mean, we have all the wearables, we have all kinds of patches, we have other ways to screen or get to people or send to people ways to screen. So, so there's so much still yet to study.
Yes.
In Germany, we would even not be allowed to get the addresses of the people to contact them.
Sweden is exceptional with registries. So, I mean, this is amazing and really interesting. Of course, for me, also comparing it to Iceland, we don't have as good registries here as in Sweden, but we know we have so much data on those not participating.
Yeah.
So that, and we have published those. I mean, we have, the reason they don't participate is there's less education, they have dementia, there's hospitalization, there's, there's a lot of things that we know from this study that we can probably use for further to see how do we get those.
Yeah. I think this is also a very interesting graph, which you also showed in your presentation when you actually looked at the cumulative incidence of stroke and embolic embolism in the different subgroups. So I think one learning from STROKESTOP 2 is certainly that the NT-proBNP, and there I'm also curious what Stephan thinks about the cutoff of 125 nanograms per liter. To position this maybe a little bit in this HFpEF idea, but maybe this in a second. But I think, look, what we've certainly learned is that that BNP is a risk marker, at least, right? So it can identify those patients at higher risk. But I think what we also learned is that non-participation is even a better risk marker than NT-proBNP, because those patients, those were the ones actually who got the endpoints, right?
Yes.
And actually, in relation to this, also, atrial fibrillation is a disease, and you're screened for atrial fibrillation. But those patients might also get stroke and embolic embolisms because of other reasons, not just for AF. So, do you think that actually just inviting individuals and actually identifying those who do not respond to the invitation might actually help to particularly identify target populations who probably would even profit from a more holistic approach beyond initiation of anticoagulation and other things?
Yes, I mean, we identify those at high risk in those that do not participate, but people have to choose what they want for treatment. They have to be, of course, we want them to take an educated risk consideration, of course, for themselves, but we aren't there. I mean, how to approach those that don't come, that is kind of the ethics there. I'm you know, that is a bit difficult, but those are the ones, of course, we should try to reach.
Yes. Stephan, the BNP cutoff. So what do you think about this?
Well, I mean, that's low. That's not very sick people.
Yeah, no, indeed.
25 in that age group. I mean, depending on the laboratory you send your blood to, that this will be considered as normal. So below 125 at an age 75, 76, that's really healthy considering heart failure. But anyway, I mean, it's interesting because it does help us. And it actually, I started in people that I've been screening for AFib in outpatient clinic to use the BNP more now and say, okay, I have a little bit of atrial enlargement, hypertensive heart disease, and then I do look at ATP pro-BNP more now. So that's an important issue from the message from the study. Well, why did you consider the 125? Have you earlier data that have a sort of linear relationship?
Yes, this was from the STROKESTOP 1. There was a subset and a sub-study where we took the last 900 and measured to see where we could put and this is a cutoff that has been used. So this is for simplicity's sake also a number, but of course we knew we would be somewhere around 35-40% that would probably be under, and of course we know also that we would miss some atrial fibrillation. This is just the area under the curve that we had to choose. So we chose this from a previous study, and I agree 125 is low in this age group, but it is. I mean, in a non-acute setting, 75-year-old, it's amazing how it's surprising being a clinician and never seeing these values in my patients that these 40% had under. I mean, they had very low even. So, and that is a good sign. I mean, then you're quite good.
Yes. Maybe there I also have one question. So STROKESTOP 1, right?
Yeah.
Also included one risk factor in addition to the age as including criterion, right?
No, only age.
No,
there was the
just
same
age.
setup. Yeah.
Okay. Because the thing is, of course, with when you have, I think 40% of patients were in the low BNP group, right? And 60% in the higher BNP group. This actually means that 40%, because of their low risk, didn't have a chance to profit from screening, meaning that actually just 60% were actually at a risk, which probably had a modifiable, amount of risk by anticoagulation and other things. So, do you think it's knowing this now, retrospectively? Do you think it's an issue of numbers of patients included, that you probably need more patients to eventually see the effect? And
yes, actually, I think you probably do. I mean, like I said, the ones that accept, if we compare the accepting group that participated to the control group, everything is lower, of course. I mean, these are, of course, observational data. These are the ones that attended. They are healthier, but they all had, in every perspective, they had lower risk than the control group. So I think, I mean, if you screen them, then we can lower the risk going forward.
Yes. Maybe a question concerning cost effectiveness and all of those questions, right? Every time when it goes about screening, we always have to consider not just the overall benefit, but also, is it cost effective? And I know there has been a cost effectiveness analysis of STROKESTOP 1. Can you maybe tell us there a little bit about, and maybe also position this now for STROKESTOP 2, which was not positive?
Yeah, well, no, well, it's not. It's, as it wasn't positive. We probably, but we did a cost effectiveness, and we plan to look at this, of course, but we haven't looked at any numbers for the STROKESTOP 2 yet. So I don't have any. But of course, if it's negative, it's negative. It's not the same. But this like screening is expensive. There are ways to make it less expensive, and NT-proBNP was a way to try to focus the screening on the high risk group, and which of course it does, obviously. So I think further studies will probably have to be on how to utilize that even better, because and how do we get those that didn't attend? How do we get their NT-proBNP?
Yeah, talking about cost. The great thing, what I learned is you ask people to participate, they don't participate, and you know the outcome. Is that right?
Yeah.
Do you, because Sweden is always at the top front in also discussing social issues. Do you?
Yes.
I mean, you know where those people live, and you know where the people are with the worst outcomes. Is there any sort of a social discussion about that? And is kind of a social or political issue, knowing where the people are, or is that far beyond? Of course, it's far beyond your targets and your results. But I really, it's a really impressing impact and really impressing design.
Mm-hmm. We have socioeconomic data on those that didn't attend. We know how they are, and there is a gradient. I mean, we know that, and that is what we did when I said we placed centers in the more deprived areas from study 1 to the 2. So we put centers in the areas that were more deprived that we had seen, and we saw that there was an increase in participation there. So if you go, I mean, we know that if you go there and if you invite people and you are close by, they're probably more likely to come. But there is a gradient, and that is something we don't want to increase that with screening, of course. That's like counterproductive. So this is, I mean, the data we have is immense, and we can work forward in trying to increase the same.
But that's incredibly important, Florian. That's an incredibly important question, and we're looking forward to all the data that's still coming from you. That same direction, I wanted to ask a little bit about the technique, because we will get more of a social gradient, and you alluded to the issue that people wear smartwatches nowadays, and we have 80-year-olds with an Apple Watch that say, I don't want to have something from the local ambulance team that they come and get me when I fall, but I want a smartwatch, and they that can also do emergency calls, and they do atrial fibrillation screening. But obviously that's costly, and that will even widen that gap to people who don't have the possibilities to buy that. I mean, that's incredibly important, and what Florian said.
Yes, and the technology is faster than the studies, so the technology is just racing, and people are. This is commercial property that people can just buy, and of course, yes, that increases the discrepancy between socioeconomic status. So. I don't know how to fix that, but
Are you still using the Zenicor device? Because I have it as well, but I used to use it in my outpatient clinic, but I actually stopped using it because I now use it a 2-week ECG patch that you just attach, and that does continuous monitoring, gives you even more data. Costs are the same. Reimbursement is one as bad as the other. So I wonder, are you still using the thumb ECG thing for further studies?
Well, actually, in here in Iceland, I am not. I'm using the patch as well, quite a bit, and I like it. And it is easy on the patients, I think, having that. In my experience, but of course you get a lot of also that data has to be worked and analyzed, and these are just 30 seconds that you have on the other one. I mean, I analyzed most of the ECGs that weren't considered normal, so I saw a lot of single lead ECGs during a couple of years there.
Yes, I think maybe also related now to this. So a patch for example, records, for example, 2 weeks, like Stephan said, continuously, and you get a good idea about atrial fibrillation burden.
Exactly.
So actually time spent with atrial fibrillation for a given monitoring period with those wearable devices, or also, for example, now this wearable ECG recorder, you get just a proxy of atrial fibrillation burden. This actually means you might have a percentage of AF recordings per all recordings, or something like this. So do you think that this also incorporates some ideas or some measures of total risk in this population? So why did you use, for example, 4 times, I think, per day, right? For 2 weeks.
Yeah.
By this, you might find quite low atrial fibrillation burden, right? Because if you just have a short one recording positive, you might get an anticoagulation. Yes, no, right? So a little bit maybe about atrial fibrillation burden. So what do you think in this screening setting?
Yes, exactly. That is quite interesting. I mean, during a continuous, you get much more information on the burden, on the real burden, and the more burden, the more risk it seems to be. Even though paroxysmal and chronic are both risky, but the more you have, the more it seems to be. But in our study, where you only had 4 times daily, if we catch it, you probably would. Of course, we're making kind of an educated guess that you probably have more atrial fibrillation than those 30 seconds. That we should be so lucky to get the only episode you have in 2 weeks is quite unlikely. So we assume that you catch those using this technology that have quite the high burden, actually. But there were patients that only had 1 episode of 56 ECGs. I mean, that is still the definition. 30 seconds episode of atrial fibrillation is still called atrial fibrillation, according to the guidelines.
Yeah. But look, I think, of course, having one recording with atrial fibrillation with 4 daily for 2 weeks is not a lot. But on the other hand, you actually have a lot of recordings with sinus rhythm where you actually excluded atrial fibrillation. So the more you record, the more sure you are that atrial fibrillation burden overall is low, right? And there, I think if you have just 1 recording, despite the fact with atrial fibrillation, despite the fact that you measure 4 times for 2 weeks, I think this is actually a quite low atrial fibrillation burden. Because you said now it was
Yes, it is low, of course, and we had those that had much more. There is a span in those. There were not many that had 1, but still, like I said, we're guessing that they probably have more episodes.
Sure.
But we don't know.
Yeah. Well, I think screening for atrial fibrillation might find atrial fibrillation, but also a lot of other stuff, right? So if you record a lot of ECGs, you might find, I don't know, PVCs, PACs, some pauses, some long PQ intervals, a lot of noise, which you also don't know what it is. So how do you deal with those things? So you also mentioned that you were looking at a lot of those ECGs, particularly those which were not detected by the algorithm easily. So what did you find?
We did not find a lot of serious arrhythmias, actually. There was, of course, PVCs, yes, there were, and supraventricular extrasystoles as well. But if I remember correctly, I think we found 8 or maybe 5 that received a pacemaker with long pauses. So I referred them to a cardiologist and to invasive treatment. And then those that had atrial fibrillation, 2 of those were referred for closure of the what do you call it, auricula? You know, the
left atrial appendage.
Yeah. So there was not a lot of downstream invasive treatment. We also found 2 valves, atrial aortic stenosis. that were operated on. So of course, yes, you find some things. If you search, we will find this in 75-year-old population. We also measured blood pressure in everybody.
Yeah.
So we found some hypertension patients as well.
I have one question
undiagnosed.
as non-cardiologist to the four of you, actually. So what we do as nephrologists, and we see a couple of surely high-risk cardiovascular patients, we try to have one ECG at least once a year to get an idea. Would that be fine for the four of you as an interval?
Should I go first? Or
Please.
Let's do a sort of vote at the end of our discussion. I think that's a good idea. You go first.
Well, we don't have any. I mean, it is a high risk. If you have any symptoms, I would probably say you could do a Holter or some kind of monitoring. But otherwise, I'm not sure. I would recommend you doing a patch every. You have to. So I think if you even do an ECG once a year, it's quite good for a nephrologist.
Florian, what do you think? Hospital doctor, obviously, a different situation.
Well, I think, of course, it's not enough to do one ECG per year, but I think this kind of BNP or risk factor approach is the best strategy to look at risk and filter those at highest risk, and then go all in. Of course, more than one ECG per year, or do it with devices screening for days. And the higher the risk, the more you find. That would be my approach.
But do ECGs, I think that's the important issue. I mean, we see so many people with coronary disease that go and see their GP, or at least the office. So they see that regularly, they get blood drawn, and then you do an ECG and you find a FIP, and then you ask the patient, when was the last ECG? And they tell you it's years ago. I mean, that's not good. I think they should, at least at the visit, and that's what the guidelines say. I mean, they say if you're above 65, take at least a pulse rate, feel for irregularities. And obviously our patients do that themselves when they measure blood pressure and they come and say there's something irregular. We should be attentive to that, I think.
Yes. So I also actually think the big difference there is, so STROKESTOP 1 and 2 were systematic screening of big populations. And I think, Gunnar, what you are referring to is opportunistic screening. So every patient who actually comes into the hospital just should get some measure of the heart rhythm, I think, which could be pulse taking, which could be also the assessment of the heart rhythm by the blood pressure monitor, or which could also very well be, of course, an ECG. And then based on the further risk, I think, and I also agree there with what Stephan and Florian just mentioned, that specific patients actually might benefit also from more intense monitoring. But I think already your outpatient clinic as a nephrologist more or less collects all the high risk patients, right? So I think if you just think about enhancement of screening again. So, for example, what Katrin did is she used the BNP as enhancement. Just being a nephrology patient is another enhancement, and I think this also might help there quite a bit. And I'm also very curious what enhancements in the future might actually come into play. It might be some artificial intelligence based assessment of, for example, ECGs, or just patient record assessment, where you actually also just have an algorithm running in your outpatient clinic in the background, and actually then you have a red flag here. This patient requires more monitoring of the heart rate for a specific time period. I think this is really where we are going for in the future. And I think this is also STROKESTOP 3, right, Katrin? So what is STROKESTOP 3? Maybe at the end of the discussion now?
Yes, well, I'm actually not involved in STROKESTOP 3 because I moved, and I'm trying to start my moving away from home, trying to start my research in Iceland as well. So I'm not involved in that, but they are comparing different sites. So I can't discuss it too much. I'm sorry. I can't. I'm not too sure on it, actually.
Yeah, but I think it's a little bit this opportunistic approach with specific subgroups of patients, a little bit like the nephrology outpatient clinic, COPD outpatient clinic. I think those are areas in hospitals where we might actually change also the prognosis of our patients when we implement there a good screening and don't let our patients with atrial fibrillation run around without anticoagulation. I think this might help quite a bit.
We also saw that in the non-participants that they have been in the hospital or they have been in contact with hospital care or patient. You know, there's a lot more contact for those patients. So we should be able to catch them, or we might be able to catch them there at their visits.
Yes.
Well, that's a good outlook. Really looking at STROKESTOP III, looking particularly at more studies from Iceland. We're looking forward to that. We don't really want to take off your time too much. We discussed beforehand that because we're so curious about Iceland, Katrin, that you may even or we would ask you to even show some non-scientific slides of Iceland. If you have that, we would be very happy at that, because we're always trying to have a little bit of a look above or away only from medicine here on our channel. So we'll be happy to see something of that. I'd like to thank you very much, though, already for joining and to this and explaining to us that's this very, very important contribution. And Dominik, I think great of you to take it into perspective with all the knowledge there is. And thanks also for joining. I think we'll have to do that more often. It was a great pleasure, really. So we'll now looking forward to what you also brought along.
Thank you very much. Yes, this was very pleasant. Thank you for having me and inviting me, and also Dominik, thanks for the chat, and all of you. I have some pictures from Iceland. I thought I would, having lived in Germany. I know you're interested in Iceland. So this is, of course, as you know, there's a volcanic eruption every 3 months or so in Iceland at the moment. So the one on the left is from 2021. That was quite a large eruption, and it went on for a long period of time. So there was a nice crater people could go and watch. And of course, we have gotten used to this, so we're not as afraid of getting close to it. So me and a friend bicycled up close in another eruption. So here you see them. And of course, as people know, there's a lot of Nordic lights or Aurora Borealis. So there you can see my place where we are at Christmas usually. And the one on the right is just taken 2 weeks ago from a summer house. The cold, clear nights are great for watching these Nordic lights, and they dance quite magnificently. And here, of course, Iceland is very hot and bubbly. So we have the geysers close by Reykjavík. So if you ever come to Reykjavík, you should take the short tour just to experience it. And you don't have to drive far to see the earth bubbling and smoke coming out of different holes in the ground. You've got to be careful, of course, where you walk, but it's a different kind of nature for most Europeans. And then, of course, what's also great about Iceland is that we don't have a lot of trees. We don't have a lot of forest. We, of course, try to plant some, but usually you see wide and far. So that is something I kind of enjoy after living in Sweden, where there's 70% is trees, and also having been in Germany, there's a lot more. The ground has been worked much more, so you can drive and walk and not meet anybody, and you see far and wide. So I would recommend visiting at some point. These were my pictures. I had to share a couple of them at least.
Yeah, thanks a lot, Katrin, for this glimpse into Iceland. And I think all four of us thinking about going there. Great pictures. Katrin, Dominik, thank you both for coming.
Thank you.
to Iceland, and to Athens, Dominik, I think, and all the best.
Yes.
Wishes to you from us for your newborn and your family.
Thank you.
And I hope we will have a good start and with those nice pictures in 2025.
Thank you.
Thank you. Bye bye.